My name is Claus Peter Heußel. I'm head of radiology here in Thoraxklinik Heidelberg, which is a dedicated chest hospital and part of the University of Heidelberg. And we are taking care of lots of patients with lung cancer, with solitary pulmonary nodules, and also with diseases like interstitial lung diseases. And we are also doing the CT-guided biopsies in those patients to derive histology.
So I'm Felix Herth, working here at the Thoraxklinik University of Heidelberg. So as a respiratory physician, I see more and more patients with smaller nodules. For sure, we have the data from the lung cancer screening trials, and yet screening is not established in Germany, but when you read the GOLD guidelines, CAT scan is nowadays recommended in the initial diagnosis of a COPD. We have cardiologists which offering more and more often cardiac CT scans, so therefore we have the indication to send the patient which has a disease in the chest through a CAT scan dramatically increasing. And therefore, we're detecting more nodules because most of the candidates going through that CAT scan have had smoking in the past, so they have a risk factor. When a patient gets a nodule detected, then you have your pathway. So we have quite good connections with our cardiologists, so it's clear the patient is sent to me as the respiratory physicians, because we cannot only take care of the nodules, we also can take care of the other diseases we are maybe seeing in the CAT scan. Yeah, not only in the NSRT, also in Nelson, in the Lucy trial now we have seen the nodule business is a business of the periphery of the lung. So therefore we will see more and more peripheral nodules, either detected by lung cancer screening programs or by the cardiologist with the cardiac CAT scan, or by other reasons why we putting patients with a lung disease through the CT scanner. So, and every data set we have seen until now clearly pointed out 80% of the nodules are in the peripheral area, so in the outer third. So we have to work on technologies that really can reach those nodules from a pulmonary perspective and that we can diagnose and maybe treat them. I believe in lung cancer screening, but I would call it lung check because we're also detecting other lung diseases, interstitial lung disease, COPD, asthma. So it's not only lung cancer related. For sure, we need screening programs, but we also need a quality control program behind that by doing more and more screening in a controlled way. So in Germany, we have been lucky here in Heidelberg because we have had the Lucy trial, so we have an idea how the situation is here in the region. We're debating at the moment with the health authority the possibilities how we implanting lung cancer screening or hopefully lung check.
Yeah, the role of bronchoscopists and radiologists in a team clarifying solid pulmonary nodules is being a team. So we should be able to send the patients to the respective procedure that is the most appropriate for this respective patient. And if there is not only a nodule but also a lymph node to clarify, then the bronchoscopist might be the person who should clarify this patient and diagnose. However, if the lesion is more peripheral or more apical in a region that is difficult to reach for a bronchoscopist, then the patient should be sent to the radiologist, as these regions are easy to access by radiology.
The nodule business will be increasing, and therefore I think people who are experienced to establishing diagnosis, so the radiologist and the pulmonologist should meet together and decide which is the best option for the patient. For example, when there is a lymph node involvement in the mediastinum, for sure I would go for bronchoscopy because I can do the EBUS, use the EBUS TBNA, and I can do the staging in the same session. But when the lesion is directly at the pleura, that will be an indication for CT guided needle aspiration now and maybe even in 5 years from now. So therefore, we really would estimate people sit together with your partner and decide together which is the best modality to come quickly for diagnosis for your patient. For sure, we have a couple of indications where they can use the EBUS TBNA scope doing the diagnosis and the staging for the patients. Another what we learned from the back, when we have a bronchus leading us to the nodule, so-called bronchosign, we can reach that nodule with the help of Sinner and Sinner bronchoscope, and also with the help of the Radial EBUS system. The other point is when the lesion is in an emphysematic part, and maybe the pneumo risk from outside is really high, then we even have the better choice to move to that nodule with the scope and biopsy it with a lower risk, especially regarding pneumothoraces. And also therefore when you have a patient who is really critically ill and you really need a biopsy, what we're knowing until now, the bronchoscopy complication rate is always a little bit lower than the CT guided rate. So therefore in those cases where I see I can reach the nodule based on the CAT scan I have, is there lymph node, yes or no, I would go more in the direction of bronchoscopy.
The challenge in lung biopsies is you biopsy a vital organ system. So if you have a complication, which might happen always, then the patient is relying on the function of this organ. So you cannot come to a lung failure for a certain period since the patient has to breathe. So either you are able to manage this complication within a few minutes, like in pneumothorax, or you shouldn't do lung biopsies. That's one of the major challenges. Another challenge is that the lesion inside the lung might be moving during respiratory cycle. And you have either to be able to manage that and to be able to hit the lesion despite it moves, or to place the patient in a way that the movement is reduced.
From a business perspective, we also can start a debate. This is a business decision. Should you do it or should I do it? There's no competition between the disciplines, that we're really focusing on the patient.
Yeah, ideally, I think if we can focus on to give the patient the option that is most appropriate for the respective patient and for the respective nodule, that would be ideal, and not to take advantage where the patient first shows up, either in your ambulance or in mine. Then if we jointly know the skills of each other and discuss the patient, and if we are in the same room or at the same table, and we decide jointly which is the best choice for the patient.
At the moment, we are limited to diagnose those nodules, but I really foresee that we will have similar technology which you are using at the moment. So from the endoscopic perspective, we are really moving in the direction of treatment, endoscopic treatment options, which then really brings both disciplines from the opportunities they can offer for the patient to the same level. Data pointing out that Europe is a little bit more conservative in doing a bronchoscopy in a peripheral nodule compared to other areas in the world. For sure, the hurdle is, can I reach that nodule when I have a low risk that I really reach that nodule? I do a bronchoscopy without a diagnostic outcome from the patient perspective. Then I send it to the radiologist, which have a higher yield but also a higher complication rate. So therefore, I think the techniques, and even what Olympus is providing now, the techniques are there. But maybe there must be better training, or it must be really established that we, from the inside, can have the same results than my friend from the outside. For sure, when we want to see more peripheral bronchoscopy, we need the complete system. So we need a scope, we need the EBUS probe who fits through, and then we need a needle who fits through the sheet of the EBUS probe, or when you go for ultrathin scope, through the working channel of the ultrathin scope. So therefore it's the package what we're needing. Yeah? And now they are there. then I really believe that in the future the number of bronchoscopy procedures for the peripheral nodules will be increasing. GuideSheath also gives me the opportunity, I can bring whatever I want to bring next to that lesion. I can place it with that extended working channel. Yeah? So it gives me the security that I'm really there. So therefore, personally, I always would try to go via GuideSheath technology. Then I have to use a little bit bigger scope. Because it's always then the question how much tissue you need. Is there a patient who will undergo surgery? Then I only need a couple of malignant cells showing its malignancy, indication for surgery. But in case it's a secondary lung cancer and the patient is not able to undergo the surgery again, or the patient has had a radiation therapy before, I cannot send him to radiotherapy, then I need tissue because I have to do all that molecular testings. And therefore, a GuideSheath even allows me to take out biopsies and bring then the needle as the next device I will use at the same spot. So it's really depending, where is the lesion? Do I have signals in the CAT scan that I can reach it by the endoscope directly? But especially in the upper lobes, I often use the GuideSheath. Especially when I have a bronchus sign in the CAT scan, then I have a high yield that I maybe see the lesion when I go in with an ultrathin bronchoscope and making a diagnosis. But I think also is an indication where I decide which scope I use. The bendability of the ultrathin is better than the bendability of a normal scope, and especially the apical segment in the upper lobes, where I really have to bend my scope. At the end, when you really want to be a player in that field of the solitary pulmonary nodules, then you have to order both scopes, yeah? Because there are indications clearly for the bigger one with a sheet, and there are clear indications for the smaller ones without the sheet. So you need at the end both scopes. So when you ask me for the future, what is coming, we're knowing that robotic assist bronchoscopy is coming. We have a lot of navigation companies on the market. So is there still a niche for the EBUS system, for the radial EBUS system in the future? And it's a clear yes. The point is when you go with the robotic assist system and when you go with the navigation system, and you always believe a virtual reality. So the track you follow is calculated by the CAT scan. But we all knowing the lung is moving because the patient is breathing, and I always want to know that I'm really there, where the GPS of the lungs guided me. So therefore I need a real-time confirmation technology. For sure you can argue when you do a diagnostic procedure, then you get a negative outcome and you have to go for another technology. But I really believe that we're moving quickly in the age of nodule treatment endoscopically. And before I would do a radiofrequency ablation or microwave, I want to know that my probe is really in the lesion. This is clearly the indication number one for the EBUS in the future, confirmation where I am. What are my advices for newcomers in the field? So it's clearly advice, do it or leave it. But when you do it, then you have to have access to the technologies which you need to reach those lesions. That means you need a normal scope and you need an ultrathin scope. You need GuideSheaths and you need a radial EBUS system. And then you can do it. For sure, when money doesn't play any role, then you can invest in navigation technologies. But actually the setup what Olympus offers you is good enough to reach lesions up to 15 millimeter in size without an additional cost per procedure. Therefore, I would really start with the radial EBUS business, building up the service, and then when you have access to smaller lesions, around 1 centimeter, then you have to invest additionally into any navigation technologies. But for the nodules we are facing at the moment, they are mostly about 2 centimeters in size, and those you can reach easily with the help of the Olympus scopes and the Olympus Radial EBUS system.